Esteemed, esteemed speakers, presenters, members of the Healthcare Conference Organizing Committee, ladies and gentlemen, good morning, and welcome to Day 2 of the 14th Annual Healthcare Conference. For those of you who were not with us last evening, my name is Ben Mead. I am your Master of Ceremonies, and it is indeed my pleasure to be with you here again this morning. Now, I trust that you all have had something to eat, and we say thanks to Infinite Mind Care for being our breakfast sponsor, feeding our bodies before we move on to the business of nourishing our minds with a lot of important information. Just a reminder, if you can keep your phones on silent or vibrate, I know you don't want to miss those important notifications being away from the office. Also, if you are on the outside for any reason while the presentations are taking place, we do ask you to be mindful of the noise levels and to moderate your conversations at a reasonable level. So, with that housekeeping out of the way, a packed agenda awaits us. Let's get straight into it. Our first presenter today is Dr. Michael Chuong. He's the Medical Director of Radiation Oncology at Baptist Health Miami Cancer Institute. Dr. Chuong is a board-certified radiation oncologist. He is the Director of Proton Therapy and Photon Therapy, Director of MRI-Guided Radiation Therapy, and Director of Clinical Research within the Radiation Oncology Department at Baptist Health Miami Cancer Institute. He is also the lead physician for the Gastrointestinal Radiation Oncology Service. Dr. Chuong will be presenting on Ablative MRI-Guided Adaptive Radiation Therapy, Improving Survival and Reducing Toxicity. Ladies and gentlemen, let's welcome Dr. Chuong.
Thank you so much, and good morning, everyone. How are you? It's a pleasure and a privilege to be in front of you today and to spend some time with you at this wonderful conference. It's my first time here in the Cayman Islands and living in Miami. It's a shame I haven't been down here sooner. Certainly will be back with my family and to enjoy your beautiful country some more. With that in mind, let me start by asking who by a show of hands has had a loved one or a friend or someone that they've known who's had to deal with cancer of any type? So me as well. So cancer touches essentially almost everybody. And cancer it's a scary thing. When you hear the word cancer, what do you think of? What are the words that come to your mind? Yeah, it's a scary word. But I see cancer patients every day in my clinic. And the words that I see, in addition to, it's normal to feel fear and uncertainty, but what I see in my patients every day is inspiration and courage and hope that they will have a great outcome. And the cancer treatments that have come across the field over the last several years have really made a huge difference in terms of outcomes, and we're seeing more cures, not just for pancreas cancer, which is what my talk is on, but across the board. And there have been advances in all fields of cancer care. So the main pillars of oncology are surgery, medical oncology or chemotherapy, and radiation therapy. And radiation therapy in particular has been a laggard in a way in terms of what we have been able to offer patients to have effective and safe outcomes. So to give you a sense, when do you think the first brain tumor surgery was done? And if you guessed in the 1880s, you'd be right, okay? So when do you think X-rays were discovered, not even used for cancer? It was actually 1895. So Röntgen took a picture of his wife's hand with the ring and figured out what X-rays were. So that was well after surgery was done for cancer. Modern radiotherapy really didn't take off until the late 1990s or early 2000s. So it really is very much a new kid on the block in a sense. We have been using radiotherapy for many years. But the point is that technology is really what drives radiotherapy. So if you think about your cell phone in your pocket, think about how different it is now and how more advanced it is and how more sophisticated it is now today than it was 5 years ago, or 10 years ago, or certainly 20 years ago. I remember my first Nokia little blue cell phone with the, and then the flip phones were cool, and Now you have all these fancy iPhones and whatnot. But really, radiotherapy is predicated on the ability to have advanced technology to deliver certain effective high dose to the tumor, but deliver as little and ideally zero radiation dose to everything else around it. Pancreas cancer is a very, very deadly cancer, unfortunately, and we will look at ways that we at Miami Cancer Institute have been spearheading efforts to not just improve the safety of what we are delivering, but also improving the longevity of how patients live while maintaining excellent quality of life. So to give you some brief statistics, so pancreas cancer actually, and it might be hard to read, but on the top are estimated new cases annually in the United States for various cancers, and on the bottom would be estimated deaths per year. So by number, pancreas cancer for men, or so males is on the left and females is on the right, pancreas cancer is not one of the most common cancers. Those would be prostate and lung and breast cancers and colorectal cancers. There are approximately just over 60,000 new cases per year annually diagnosed. But if you look at the incidence of death from pancreas cancer, there is a discordance there. So it is among the most deadly cancers, although it is not the most common cancers, which really points to the fact that we need more advanced treatments. This is a statistic that just came out this year in 2023. The 5-year survival rate for pancreatic cancer has increased to 12%. The previous year, it was 11%. And this was the first time in a long time that there were 2 successive years with an increase in long-term survival. So while that is wonderful and increasing survival is great, that 12% number seems very low to me, and it probably does to you as well. And what can we do to continue that increase beyond 12% and hopefully much, much more beyond that? This is a little bit of a busy graphic, but if I would highlight, or if you focus on the top left image, this I think really drives home the point of why pancreas cancers are so difficult to treat. The pancreas is the tan, horizontal sort of organ there, and it's an organ that makes digestive enzymes and helps control your blood sugar by making insulin, okay? It's in a difficult location because it sits behind the stomach, and then the intestine, so this is the stomach, the intestine then wraps around the pancreas here, okay? And these blue and the red areas are major blood vessels. So the blue is a vein, and the red is a major artery. And so what you can see in a cross-section here on the right is that tumors, so this blob or these blobs here are different amounts of tumor in different situations. And so really what drives prognosis for pancreas patients is how extensive is that tumor, specifically related to these blue and the red structures, the blood vessels. So you can see here that this is a tumor that's not touching these blood vessels. Here you see more involvement of these blood vessels. And here on the bottom right, you can see complete encasement or surrounding of those blood vessels. Excuse me. So ultimately, surgery is the only known curative treatment for pancreas cancer, provided that there are no metastases or there's no spread to other organs like the liver. If there are no metastases, whether surgery can be done or not is really predicated on the extent of the blood vessels that are involved. If there is no blood vessel involvement, then surgery is something that's feasible. However, if blood vessels are somewhat involved or definitely involved, then surgery probably is not an option, and therefore non-surgical treatments like chemotherapy and radiation therapy are routinely used for these patients. And not surprisingly, the survival rates, so picking a 2-year endpoint, decreases as you have more tumor involving the blood vessels. And we'll want to remember that 2-year survival number of 20%. These are for truly unresectable locally advanced patients, which is the bulk of patients that I see in my clinic and for whom a very, very new state-of-the-art type of treatment and technique that's improving outcomes that we've pioneered at Miami Cancer Institute are making waves in the oncology world. So why is pancreas cancer so deadly? I've already alluded to the fact that metastases are very common, unfortunately. So this is a CT scan from a patient who has multiple liver metastases. You can see those gray blobs on the left. But also, this is going to advance. The circle here shows that dark gray area here is a very large infiltrative tumor that is growing into the stomach, into the intestines, can cause obstruction of the stomach, can cause bleeding, can cause pain. And so both of these are causes of, unfortunately, death for patients with pancreas cancer. How do we deal with metastases? That clearly is chemotherapy as the primary treatment. But despite chemotherapy, sometimes you can end up with the situation on the right where you have local progression of tumor that can lead to symptoms that could result in unfortunately, death. Now, radiation therapy, and when I say radiation, I mean the standard type of radiation that you would get at most radiation clinics, is something that reduces pain. It can slow tumor growth, but never has been shown to improve patient survival. So it effectively is palliative in nature, and there's a reason for that. The radiation dose that we deliver for certain tumors in the body is higher than for other locations. And that's not necessarily because radiation doses are more effective in the brain versus less effective in the pancreas and more effective in the prostate. It really is driven by the ability to deliver a certain high dose of radiation to the tumor while sparing radiation from the surrounding organs. So to give you a sense, pinpoint sort of what we call ablative or high dose radiation is routinely delivered to many lung cancers, and effectively the long-term survival outcomes for early stage lung cancer, delivering high dose pinpoint ablative radiation is equivalent to surgery, believe it or not. So for early stage lung cancer. So we deliver a very high dose of radiation for those tumors. Also for brain tumors, it's very common to deliver high dose radiation with a procedure called stereotactic radiosurgery that can eradicate tumors without a scalpel. But if you look at pancreas cancers, the standard of care is much, much less than what we deliver for other tumors. And the question is, why is that the case? And can we do something about it? And can we improve the dose to pancreas cancers and therefore improve outcomes? Not surprisingly, delivering a higher dose of radiation to a tumor kills more cancer cells and leads to better tumor control. So the lung cancer example I told you before with a much higher dose can achieve a 2-year survival rate, for example, of close to 100%. Pancreas cancers, however, it's about half of that. It's about 50% tumor control, and survival rates obviously are not very good either, at least with standard radiotherapy. What are the limits of, why do we not deliver the same dose to lung tumors as we do to pancreas cancers? And the reasons, there are multiple reasons, excuse me. In that, one is that the image you see on the left, you would say that that's a really clear image and you can clearly see the intestines and the stomach and all the other organs. I mean, you may not look at scans all the time, but you can probably see it's a pretty fuzzy image. You can see some black areas and gray areas, but there is no clear delineation of the organs. This is an image taken from a patient on a standard linear accelerator that uses CT scans. There's a CT scanner built in that images the patient right before the treatment is done. And this is the quality of image that is standard on the most advanced, what are called linear accelerators or radiotherapy devices. So if I saw that image, would I feel confident, or if you saw that image and you were me, would you feel confident of delivering massive amounts of radiation into where you think the tumor is, but you're not sure if it's really the intestine? And you could put a hole in the intestine or kill somebody? I mean, obviously not, right? I mean, you can. So there are trials that actually have shown that, have attempted to deliver ablative high-dose radiation for tumors like this, using images just like this, or even worse, and patients died, okay? And so that is a major limitation in terms of the image quality. The image on the right is an MRI scan, and we don't use these scans as part of routine treatment, but the point is that our insides move, and they are constantly moving, right? So this is just a time lapse of intestines moving and patients breathing and the heart moving. So nothing is static in your abdomen. So if you're trying to deliver a very, very high dose radiation beam to a tumor that you can't really see well, that's moving around and the intestines are bouncing around, and patients come for treatments multiple days, and of course the intestines and the stomach are going to be even more different from one day to the next, there really is not a high level of certainty whatsoever that you can safely deliver those high doses. And getting to the point of, this has been attempted before to deliver ablative radiation for pancreas cancers, and you end up seeing images on the right, which is basically bleeding intestines. Okay, you can cause ulceration and bleeding, and that can lead to death. And so we know that this is not safe to do, with even the most modern types of linear accelerators. One thing that is unique and one thing I'm proud of being able to offer patients who come to MCI is that we offer all of the state-of-the-art radiotherapy devices under a single roof. So some institutions offer some or maybe even all of these, but at separate centers across a region, which makes it difficult to really easily offer patients one or another. So if a patient comes to my clinic or our clinic, we are able and actually obligated, in a sense, to offer the patient what we think is the best for them in terms of their radiotherapy device. Standard linear accelerators, which is what any general radiation oncology clinic, those devices can treat patients, essentially almost every patient, with some form of radiotherapy. Really the question is that the best radiotherapy for that particular patient and for that particular cancer? So just because you can do something decently okay, I would argue that if I was a cancer patient, I would want the best for my particular diagnosis in cancer, and that is what I'm proud that we can offer at MCI. And that includes everything from the most advanced proton therapy to something called CyberKnife, Gamma Knife, which is a radiosurgery device for brain tumors, and something called the Meridian Linac, which is the focus of our discussion today. And categorically, for patients with unresectable pancreas cancers or other cancers for that matter in the body, the Meridian Linac, from my standpoint and from my experience and from my opinion, and our data would show that the Meridian Linac is something that is categorically superior to the other devices. This is the device that I'll explain a little bit more about, but we were among the first in the world, the second in the United States in 2018 to start treating with, and really have led much of the global training for other centers in the world in terms of how they treat. So the image on the left probably looks will look similar to the image I showed you before, that fuzzy image that we really couldn't distinguish the intestines from the tumor. The image on the right is obviously much clearer, right? You can clearly see the intestines, you can see the spinal cord, you can see the spleen. So this is an image that's an MRI image. So MRI scans inherently offer superior soft tissue contrast as opposed to CT scans. So when patients are diagnosed with abdominal tumors or other cancers, regardless of if they get radiotherapy or not, MRI is a standard type of diagnostic treatment or scan to better delineate the tumor as opposed to CT scans, okay? So it would only make sense that if we're treating tumors in this area with radiotherapy, that we also use the same type of superior imaging for targeting and accuracy purposes. The Meridian device is the first device in the world that uses MRI instead of CT scans for targeting purposes, allowing for much improved confidence from the radiation oncologist that what is being treated is actually where we think it is, in addition to some other important capabilities of the device. So clearly, more accurate targeting is important. What this video here shows you is also another profoundly advanced type of advantage of this type of platform. So when patients are treated with standard linear accelerators using CT scans, that CT scan is actually not acquired throughout treatment. It's one snapshot in time, just prior to the treatment, but once the treatment starts, technically there's not a way to continue imaging inside the body. For some tumors that do not move, for example, brain tumors are not going to move as the patient is treated, but for example, tumors in the chest or the abdomen and even in the pelvis, those tumors can move substantially as patients breathe or as the intestines move. And so accounting for that and visualizing that is critical to delivering higher dose radiation and having more effective treatments. What you're seeing here is real-time MRI that's being acquired throughout the patient's treatment from the beginning to the very end of treatment. And what you can see here, there are two colored circles. One is green and one is blue. So the green is automatically, so we tell the system, this is the tumor, and don't take your eyes off the tumor. When the patient moves or breathes, you can see that outline tracks along with the tumor throughout the entire treatment. And not only can we see or track the tumor, but we can also do something about it in terms of the motion if the tumor is moved out of the area that we intend for the treatment to be delivered to. And so if you pay attention to the bottom middle where you see that flashing image, you'll see that it says beam off, and then it'll go back to beam on. So essentially, when the tract area where the tumor is, if it moves out of that blue area, the system knows automatically that the tumor is not in the right place, and it will stop treating, and that is an automatic thing. If it moves just a few millimeters or actually sub-millimeter outside of that area, the machine will stop treating. So that is an incredible ability to not only prevent missing the tumor when we're treating, but also if the tumor moved out of the right area, that means something else moved into that area. And that probably is some of the intestine or the stomach. This is something that has never before been seen during radiation therapy of any kind whatsoever. And it profoundly has affected and impacted how we treat patients. And then last but not least, so I mentioned that patients come for radiation nearly always over multiple days, if not multiple weeks. Your internal anatomy obviously is not set in stone, especially in your abdomen. And so what this is showing is that as opposed to standard radiation, which is you would basically come and get treated to the radiation goes to the same place every single day, even if there are changes inside your body, there's not a way to quickly modify or sculpt the radiation dose out of the areas where the changes happened. This device overcomes that and lets us sculpt those radiation doses every single day to match the shape of the tumor and to avoid delivering high dose that would be going, for example, into the intestine. So you can see from one day to another here, we are what's called adapting the radiation, and this happens with the patient lying in the machine. They don't come out. We scan them with the new MRI each day. We see those changes, and there's a whole team of people. It's almost like going to a virtual OR each day with a team of physicists and physician and radiation therapists, where we sculpt the radiation doses out of the intestines and make sure the high dose is only going to the tumor. And this is an example. The colored lines just represent different amounts of radiation dose, and you can see that this tumor in the middle, that's where the colored lines are located, and they're not overlapping into the intestine. So incredibly safer treatment than what you would expect otherwise. And so all of these capabilities combined have allowed us to give the same dose now as to lung cancers, brain cancers, and other cancers where I showed you that this high ablative dose results in long-term local control and high rates of survival for other cancers. And this is the first time really in the history of oncology that we've been able to do something like this. And not too long ago, it was thought to never be possible. And now this is something that is a standard of care at centers like Miami Cancer Institute, although globally, or even, I would say at most centers, even within the United States, this is not being done. This is something that, if you remember the prior graph where the pancreas dose was low, that is currently still the standard of care because this technology does not exist at most centers globally. We are one of a small number that are offering this. It is growing over time, but it is something that is not routine, just so you have a sense. So what can we expect, or what have we seen from our clinical outcomes from doing this type of procedure with high-dose radiation? And so when I say complete tumor eradication is common, I mean complete tumor eradication is common. So these are patients who I'm seeing with large tumors that are not surgically resectable, 8 to 10 centimeter tumors, that even low-dose radiation many times would probably be not even, you'd have a question as to whether it's even safe with lower dose radiation. But following patients for the last 5 to 6 years, there's a large percentage of patients without undergoing anesthesia or going to the OR or having a scalpel, IV contrast. We've had great success in eradicating these tumors entirely in the pancreas. And this is a treatment that's very, very sort of easy to do in a sense, meaning patients come, it's a 5-day treatment done as an outpatient. There's no anesthesia, there's no contrast. I don't need patients to drink anything. I don't need them to have an IV with anything. They come, they lie down in the machine for about 30 to 40 minutes a day. Most of that time is just getting things ready, getting a new MRI scan, sculpting the radiation doses, and then the treatment itself is maybe about 11 to 13 minutes at the end of all of that. Patients get up, they go back to work, go home, go to the beach, whatever you want to do. There's no restrictions, and effectively there's no downtime. And this has really allowed for patients to come from near and far for this type of treatment, and there's some slides showing, but this is really something that's conducive to patients coming from great distances to get treated, and patients are able to go home right after treatment effectively. So I had a patient, I'll show you her case, fly from Thailand, land, get treated for 5 days, got on a plane the next day, went home, had no issues, and she's doing wonderfully right now. And just to give you, a visual, because I think visuals are very effective. So this is a tumor. This is a PET scan of someone with a large pancreas tumor, and the bright area is the area where the tumor was before radiation. And these patients typically will get some chemotherapy first, but very rarely do the PET scans ever become completely negative on chemotherapy alone. And what you can see here is that bright area is completely gone. This is in a patient who was several years out after radiotherapy and had not had any tumor come back. And it's clear evidence that the radiotherapy was highly effective, and she had really no side effects whatsoever. Excuse me. So we've been proud to be the leaders academically in this field and have published the majority of the data demonstrating the safety profile as well as efficacy of this treatment. This was a publication that we had put out a few years ago. This, I think, it was in 2020 or 2021, which was the first publication in the world describing initial outcomes in patients treated with this approach. And effectively what this showed was that most patients, nearly all patients, had no major side effects from this. And in fact, the side effect rates were actually a bit lower than what was typically expected and had been published with sort of the standard lower dose radiotherapy. Especially exciting to us was when we looked at how patients did long-term, not just in terms of how they felt, but how long they lived. We saw a dramatic difference in patients who were treated with this type of ablative MRI-guided radiation therapy. So I told you before to keep in mind that 20% number at 2 years for patients with locally advanced unresectable pancreas cancers. And so when we looked in our experience, which is quite large now, over several hundred patients, we saw something that we didn't expect. We saw that patients not only had better tumor control, but they actually were living longer. And it wasn't just a little bit longer, it's a lot longer. It's doubled what you would expect with standard radiotherapy, 50% to your survival. And if you look at the outcomes from patients who had smaller tumors, who could have surgery up front, the 2-year survival rates, what do you think that looks like? It's actually about 50%. So by no means am I here in front of you telling you that this is a replacement for surgery, but what I can tell you is that the outcomes from our center and others have clearly shown that there is something to what we are doing with this approach, and potentially there could be a dramatic improvement in overall survival, and we're looking at some prospective trials to prove that. Why would survival be any different in patients who get higher dose radiation versus lower dose radiation? And so what the reason might be is what I alluded to before, in that death is not always because of the spread of tumor to other organs or from metastases. This is a pretty well-known autopsy study from Johns Hopkins University that showed that even in patients who had metastases, that about a third of deaths actually were because of local progression of tumor. So it stands to reason that if we were able to prevent or at least substantially delay this progression locally, that we could impact overall survival. And I think that probably is the most likely mechanism of how we are impacting long-term outcomes here. To give you a sense, and this is to give you a sense of how sort of feasible it is to travel and get treatment. This is a patient, her name is Connie, so she was actually referred to me from Mayo Clinic. And actually her tumor was one of the most extensive tumors that I had actually seen in my career. Very, very large tumor, unresectable, and a lot of lymph nodes throughout her abdomen. She was deemed not a surgical candidate, and so she received chemotherapy for about 6 months. It worked a bit, but she still had tumor there. She didn't have any growth elsewhere, and so she was evaluated at Mayo Clinic and by the radiation oncologist there, and the radiation oncologist said, "This is just too big. I can't treat you, even with standard dose radiation. It's just going to cause you too many side effects." And so he started looking, and he found the work that we were doing and sent her to get treated at Miami Cancer Institute, specifically with this ablative MRI-guided radiation therapy. So she and her husband actually, this was during the middle of the pandemic, so she actually drove to Miami as opposed to getting on a plane, got 5 days of treatment, relaxed in Miami on the beach every day after a treatment, felt really well, drove home afterwards, and to this day, she's about 2 years out from treatment now, she has no evidence of cancer whatsoever. No. So it's really incredible, you know? And you know, the amazing thing about this is that she is not an outlier. She is someone who is very representative of the outcomes that we've seen. And obviously, some patients do develop metastases afterwards, but there is a large percentage of patients who have no evidence of tumor for a long period of time at least and can stay off of chemotherapy for a long time. And there are some patients who have no tumor that comes back for, I've had patients not ever have tumor come back and they pass away from something else. So I think there's something to what we're doing. But the point here is that this is a very common situation, and it's very common that we have patients come from outside the region, patients from as far as Seattle, Washington, internationally, and patients who could get radiotherapy with standard radiation closer to home are seeking us out because they want something that offers them more hope, and we have tangible data to support what we're doing. She said she felt no pain or discomfort at all, and she felt nothing when the radiation was delivered. So this is something that's really well tolerated. To give folks a sense of at least the national reach in the US of where patients come from, if this advances, this just gives you a sense of patients who've traveled to us from across the US and also internationally for treatment. Just to give you an example of this is a patient from Thailand who I mentioned before, so she was in her 70s, had a pretty large 8-centimeter pancreas tumor. It started to grow on chemotherapy. Her daughter actually saw some of our publications, including some of what I showed you, and actually self-referred herself. She actually sent me a message online, and she came to us last year, flew home 2 days later. Her tumor, which was growing previously on chemotherapy, had begun to shrink substantially. This is a graph of her tumor marker, the CA19-9, and whereas it was increasing before the radiotherapy, it had come down substantially. So I just talked to her a few days ago, and her mom's doing great, and her tumor marker is normal, and she's living a great quality of life. So it's pretty incredible. So what we try to do is treat patients based on data. So it's not just our institutional experience and what we think, but what do are there prospective trials, and is there a larger body of evidence that supports that this is something that is beneficial to patients. So this is something called the SMART trial. So it was a phase 2 clinical trial, and I was fortunate to be one of the international PIs on the trial. That is the largest ablative radiotherapy trial ever for pancreas cancer. Excuse me. And it treated patients with the 5-day high-dose radiation that I just described to you at 13 centers in the United States and Europe. And so the primary goal of this was to show that, as opposed to the standard radiation approaches or other types of attempts in the past that caused major side effects that we talked about before, this was a trial that aimed to show prospectively that this, in fact, was safe to do, and that it could be done at multiple centers and not just specialized centers like MCI. And we, in fact, were one of the highest accruers to this trial. And what it showed was that major toxicity from this treatment that was related to SMART, which is an acronym for the radiation, so stereotactic MRI-guided adaptive radiation therapy, was 0%. And as one of the folks involved in the design of this trial, I did not expect to see 0%, but it was 0%, as adjudicated by a completely independent committee that had nothing to do with the trial conduct itself. They just reviewed all of the records. So this is clearly safe. And the 2-year survival, that 50% number comes back. So that 2-year survival number was right around 50% or so. Really remarkable data supporting how we are I think changing the paradigm. So that was toxicity actually judged by the treating physician. What do patients say? And what are the patients' experience, bringing back to sort of the theme of this conference? One thing that we looked at, if you look at the secondary endpoints, the bottom one was patient-reported quality of life. So how did patients report that they felt either 3 months or 12 months after the radiotherapy compared to before? And so this was a survey that all patients were asked to fill out. And not to go through all of the nuances of this, but it asked questions related to different domains. So one was, how did they physically feel? Emotionally, how did they feel? Treatment side effects, and then their function or well-being. How did they do with that? And we looked over time. So most patients filled the survey out at the first few time points. And when we look at before treatment and after, this was comparing just to 3 months after the radiation, there was no significant change in any of these subdomains. So it wasn't that patients were clearly feeling worse afterwards. They were maintaining a good quality of life. When we look at the individual questions, there actually were two areas where there was a difference. So general pain and stomach pain were actually a bit increased after treatment. And so when I saw the data, I wondered, that just seems a little bit interesting, right? Is there a subset of patients where this is happening in, or is it everybody? So the one thing that was allowed after the radiation was, if your scan showed that you had a great response, you could actually move on to surgery. And so when we looked at the outcomes based on surgery or no surgery, so the patients who did not have surgery are on the left, and the ones who had surgery are on the right, we actually found that the differences in pain were coming from the patients who had surgery and not from the patients who had radiotherapy alone. Which makes sense, right? If you had surgery, you're going to have pain, and that is expected to be temporary and non-long-term, but nonetheless, it really confirmed that patients who did not have surgery had excellent maintained long-term quality of life. This is a trial I'm very excited about and proud about. It is a phase 3 international randomized trial looking at whether this treatment definitively improves survival in this patient population. So the trial I mentioned before, the phase 2 SMART trial, was what's called a single-arm trial. So all patients received the same treatment. It was chemotherapy, then the 5 days of radiation, and then potentially surgery. This is a trial that is comparing chemotherapy alone, which actually is the global standard of care. So if you went to different parts of the world, they would actually tell you radiotherapy has no role whatsoever, even lower high dose. We're just going to give chemotherapy for patients who have locally advanced unresectable tumors, and radiation has no role. So one arm is comparing that, so patients will just get chemotherapy. The other arm would be chemotherapy followed by this high-dose radiation therapy. And what we're looking at is whether, in fact, there is a large difference or a significant difference in overall survival after several years. And if it is positive, it would be the first trial to actually be positive from a survival standpoint in the history of pancreas cancer to show survival benefit for radiotherapy of any kind for these patients and could define a new standard of care. There's a global PI team here that I won't go into in detail, but it's really the who's who in pancreas cancer. And I will highlight Eileen O'Reilly, who's one of the international names and experts in pancreas cancer from a medical oncology standpoint, who's based out of Memorial Sloan Kettering in New York. And then with the last few minutes, I wanted to touch on something that is something that could be pushing the envelope a bit more beyond just the radiotherapy I just explained to you, that could be helping also change the paradigm of how these patients are managed. So it's a morbid topic, I know, especially for a 8:30 a.m. talk, but when we look at why patients die, going back to that, it is obviously a combination of some patients develop metastatic disease to other organs, and some patients have progression in the pancreas. If you take a step back and actually look at, if you take the earliest stage patients who can go to surgery, so small tumors, they have upfront surgery, which could provide cure. How do those patients recur, and why do those patients ultimately die? And unfortunately, even early stage pancreas cancer patients have globally or collectively have poor long-term survival because tumor recurrence or tumor coming back is a very common phenomenon. So it turns out that the majority, and we looked in our series at why patients who received ablative radiation therapy ended up passing away, specifically of we looked at the different causes. And the summary from this is, if you look at the very, very bottom, local progression as a cause of death was under 10% at 7%. So if you compare that to what has been reported before of upwards of 30%, there's a signal here that what we are doing is preventing many of these deaths that otherwise might have happened without radiotherapy or with standard low-dose radiation. The other finding here is that metastases were the most common cause of death in these patients, as is well known from a lot of studies in the past, especially from tumors in the liver and in the peritoneum. So the peritoneum is the inner lining of the belly, and there are many studies to show that in resectable patients or unresectable patients, this is the most common site of tumor coming back, and that ultimately leads to fatal complications in the majority of patients. And this is despite patients potentially receiving many, many, many months of chemotherapy, despite receiving 6 to 12 months or more of chemotherapy. So ultimately, there are some cells that have some resistance to the chemotherapy that lie outside of the, or that are just not effectively killed by the chemotherapy. So if we are effectively able to eradicate the tumor in the pancreas in most of these patients, and if they otherwise in the future would come back or are likely to come back with tumor elsewhere in the abdomen, is there something that we can do about it, knowing that the chemotherapy that they received before probably didn't eradicate those cells if they are there? There is a novel type of treatment called tumor treating fields that has changed the landscape for some cancers that are extremely deadly. So for example, for tumors called glioblastoma or GBM, it's a very, very aggressive type of brain cancer. And it's a type of cancer that is treated with surgery, in some cases, but otherwise radiation and chemotherapy. But unfortunately, GBM is a deadly disease for nearly all patients who have a diagnosis of it. When there were some randomized trials looking at standard radiation chemotherapy and surgery alone versus with this device, and I'll tell you how this works. The patients who received this treatment as well, this tumor treating fields treatment, had substantially longer survival that led to expedited FDA approval as a standard of care and as part of national guidelines now for GBM. This is now being evaluated in tumors outside of the brain as a means to potentially improve outcomes, especially for patients with very difficult to treat cancers. So effectively what this is, and it's a little bit, it's very, very different than other treatments, so it takes a little bit of some explaining to understand what the treatment is. But effectively, it is a treatment that delivers low-dose electrical fields to the cancer cells or to a region of the body where there could be cancer cells where we know there's cancer, that results in the inability of those cancer cells to divide over time, and ultimately those cells will die. And so this is what it looks like for someone who has pancreas cancer. Effectively, there are these arrays, or they're basically sticky pads, that are, there's opposing arrays, so one in the front, one in the back, one on the left and the right, and the color images on the bottom you can see represent different electrical fields. So this is not high voltage, shocking people, but this is very, very low dose. Patients don't feel anything. They just wear these pads on their skin. They carry they have a little knapsack, and there's a battery-generated electrical field generator that they carry around with them. There's a lot of preclinical and growing clinical data that this is effective for many cancers and basically interrupts the cell division process, and I won't go into this in detail. And there's some exciting data for pancreas cancer. So this was a study looking at adding tumor treating fields to chemotherapy, and effectively what you see here is that the tumor volume and the control, which was cells that weren't treated with anything, versus gemcitabine, which is a chemotherapy, versus tumor treating fields alone, versus the combination. Ultimately, the combination led to the lowest or the most effective outcome. So they had the smallest tumor at the end of the day. There are some emerging clinical trials outcomes. This is something called the PANOVA trial, which basically looked at combining chemotherapy with this tumor treating fields device that showed really provocative outcomes in terms of improved survival and progression-free survival with the addition of this device compared to gemcitabine and paclitaxel, or not paclitaxel, which is another type of chemotherapy. There's an ongoing international trial looking at randomizing patients to chemotherapy alone or chemotherapy plus this device. And then on the heels of that, something I'm very excited about is a trial that we have enrolling at Miami Cancer Institute, which is the first trial in the world of combining radiotherapy and tumor treating fields for really any cancer. But it is combining the same ablative radiation that I just explained to you before with tumor treating fields. And so the idea was that the vast majority of our patients long-term do not have tumors come back in the pancreas. In fact, we have great evidence to show that they are completely eradicated. But unfortunately, the majority of our patients do and did have tumor come back in the liver and the peritoneum. So the hypothesis is if patients wear this device over those areas in their abdomen, could we be eradicating those microscopic cells that probably are there for a lot of patients and ultimately improve their outcomes? So it's combining these two different treatments. So it's a first in the world. It's something that we are very optimistic about and something that is currently enrolling at MCI. So that was a lot of information, but the conclusions I think are that MRI guidance has fundamentally transformed the entire field of radiation therapy, and that we are changing the paradigm of how many cancers, including pancreas cancers, are treated. I mentioned before that the standard treatment for pancreas cancer with radiation is palliative, but I would argue that we are on the path to curative outcomes for at least some of our patients, which was never before thought to be possible. I'm really proud that we have become an international leader in MRI-guided radiation, and I would mention that this is not just for pancreas cancer. So most of what we treat on our device is pancreas cancer, just because there's so many patients from all over the world that come to us. But this is a device that we routinely treat lung cancers and prostate cancer and liver cancer and adrenal cancer and kidney cancer, so a lot of brain cancers. And so this is something that is really applicable to many types of cancers. There's a lot of promising combinations with this type of radiation and other treatments, as I explained in the last trial. And I think the most important thing, going back to what we started with in terms of how patients feel when they get diagnosed with cancer and go through different treatments, is that there's so much hope in the patients that I see who come to us, seeing the data that we've generated, and also the hope in patients after they've been treated and the scan results look wonderful, and we're very hopeful that they will continue to look that way, and for many patients they do. So with that, I thank you. In order to get in touch with us, if you have questions, I'm glad to chat with folks afterwards, or you can reach me virtually. The Baptist International office here is very able and willing to connect anyone who has questions. You can see the contact information on the slide here. And very glad to chat with anyone who would like to do so. So with that, I thank you, and I'm glad to take questions.
Thanks, Dr. Chuong. Now, I know he has shared his contact information, but we do have a provision. If there are any questions, we can facilitate any questions you may have at this stage. You can just indicate by a show of a hand, and we will get the microphone to you. Just making a scan. Okay, we have a question at the back there, and then we'll have one at the front here.
Good morning, Dr. Chuong.
Good morning.
Sorry.